Well, hello and welcome. Good afternoon, and thank you very much for joining this webinar with Spacestore this afternoon, Spacestore Healthcare. And just like to welcome everybody who's joining us. Just while you're getting logged in, maybe we can make some introduction just to give a little bit of context to the conversation today. So my name's Alex Harvey. I'm VP of Sales with Spacestore. I'm actually dialing in today from our design centre in New York. So very excited to be joining you on a cold and frosty New York morning. But wanted to give you a bit of background to who Spacestore Healthcare are and some of the background to this conversation. So the whole topic of the conversation is around the subject of virtual consultation and how we can use virtual consultation to firstly redesign patient care and secondly transform real estate. And to obviously look at the backdrop, we've seen over the last 12 to 18 months, NHS organisations, health and care systems have had to move very quickly to implement virtual ways to deliver care in response to the pandemic, in response to the changes that have happened and that have affected all of us in our lives. And this shift has really, I think it's forced us to innovate in ways we may have never thought of before, and find new ways of working, new ways of connecting. I guess you might say a new relationship with the public and a more integrated way of working within and between organisations and systems and professions. So I think virtual care has been a critical lifeline throughout the pandemic. It's enabled the health and care sector to support and care for patients and communities in a way that they wouldn't otherwise have been able to. But given the backdrop of where we are now, given the high case numbers of Omicron, given the large backlog that there is within the system, we wanted to kind of readdress the whole virtual consultation topic and see how does it fit? How does it fit now? What's the future of that? And how can we share insights and experiences from Spacestore and also from some of our panelists who have experience? And maybe just to give just a second or two on who Spacestore are and what we do. So Spacestore create workplace furniture, and we've been creating workplace furniture for nearly 30 years now. That's a blend of California cool and London design. So we work with many of the large corporate clients globally. We work with many of the tech companies and financial firms. And one of the trends that we've seen emerging over the last 2 years, really, and also prior to COVID, was an increase in video calls. We're all on video calls now. That's the way we're collaborating. And we have created an acoustic modular plug and play pod, which gives you the ability to have those video calls and bringing together the blended requirements that brings about. So the need for acoustic privacy and confidentiality, the ability to create these acoustic environments, to deploy them quickly, but also maintain future flexibility as a modular product. We may need to shift and move that as things change in the future, but also very, very importantly, to create a great user experience from an ergonomics and a comfort standpoint. So things like great ventilation, the adjustable lighting so that it's as inclusive and gives the best digital experience to every user, no matter what their skin color or skin tone is. The ergonomics of the environment so that it's comfortable to use, particularly if you're in there for a 3.5-hour clinic. So if you'd like to find out more about the products, we're going to have some calls to action at the end, and you can book to join us either on a virtual or physical tour in one of our UK-based showrooms in London and Manchester, or join us in one of our showroom open days. But I'd like to introduce our panelists today, because we're joined by a stellar group of panelists and going to be really interested to hear their insights and their viewpoints around this whole subject of virtual consultation and how it can be used to redesign patient care and transform real estate. So move first to you, Steve. So Steve Levers, perhaps you could introduce yourself and give some background to your experience within the NHS and with virtual care.
Yeah, thanks, Alex. My background is, for the last 15, 17 years, been a turnaround director in the NHS. I've worked in some of the largest organisations in the NHS, acute trusts, mental health trusts, community trusts, but my role has been to work with organisations that are in either financial special measures or quality special measures and support clinicians and managers to help fix those problems. My background is that I'm a nurse. I've been a chief nurse and a chief operating officer at executive level in more than one trust, and moved into turnaround in response to what I saw as a real need for somebody from a clinical perspective to lead that work rather than being led purely by spreadsheets and accountants. Over that time, I've worked on programs that I've saved in the order of £850 million. So I have been doing this for a while. It has been successful. Now working across a range of different specialties.
That's great. Thanks, Steve. And thanks for joining us. Very happy to have you with us today. And then we also have John Hyam with us, who's from the Birmingham Community Healthcare and NHS Foundation Trust. So over to you, John, to give some background and an introduction.
Thanks, Alex. Well, my day job is a consultant in oral medicine at the Birmingham Dental Hospital, but part of my role is as the Chief Clinical Information Officer at Birmingham Community Healthcare. In response to the pandemic, I was tasked with implementing remote consultation. And so we've been on quite a journey with remote consultation at BCHC, and we feel that we've achieved quite a lot in that space. And so hopefully we'll be able to share some of those insights today.
That's great. And again, very happy to have you with us. Thanks for joining us. So maybe we can kind of open the conversation with a few questions. And what I'd like to do is invite the audience who have joined us muted, so you're not actually able to speak up, but feel free to use the Q&A box to drop any questions in. And if you've only just joined us, welcome and thanks for taking the time to listen to us today. We're going to keep our commitment of finishing on time. So we've asked for 45 minutes of your day today, so we'll be finished by 1:45. But maybe we can kick off with a kind of a bigger picture question, John. I'd be interested in your views around kind of why virtual consultation in the first place, and I guess segueing off that, is this shift to virtual going to be something that you see as a sustainable long-term change, or is it just a short-term necessity that's helping us in this current pandemic and we'll go back to the old way of working once that's passed? Glad your thoughts on that, John.
I mean, I think the why is fairly obvious in the context that we find ourselves in, and the majority of provider organisations have gone to some extent transferred to remote consultation, be that telephone, be that video, and it's obvious the benefits in terms of infection protection and reduced footfall in our estates. But going forward, I think the experience that we've had and the feedback that we've had from our patients in particular is that patients like it. It's convenient, it's easily accessible. They're not having to take time out of work or school. And as a result, whilst it can't be used in every situation, it isn't appropriate to be used in every type of clinical contact. Where it can be used, I think we should be building that into our business as usual going forward. And I think it would probably be useful now for us to start divorcing remote consultation from the pandemic. We always seem to talk about it in the context of COVID and in the response to COVID. I think as we move forward, I think we need to sort of leave that behind. The pandemic has allowed us to achieve what we've achieved in implementing remote consultation at scale and at pace. But going forwards, we should be using this as business as usual.
Yeah, that's really interesting, that divorcing the kind of the necessity that's happened because of COVID from the bigger move forward that it potentially will bring. And be interested in your views, Steve, around the comments John was making. It's sometimes better, is what I heard him say, or kind of paraphrasing, but not necessarily. What would you say from your nursing background perspective?
I think from both a nursing background and from a change manager's background, I'd agree with everything you said on that, John, rather than argue with anybody. But I think there are lots of reasons why I think we should embrace this. And I agree with you that we shouldn't consider what we're doing as being just the solution to COVID. So as an example, for instance, if I go to see my GP and I have a list of things that I want resolving, my GP can do all the diagnostics, can talk to me, can do a consultation letter to a consultant like John at an organisation who has that information before he ever meets me. And one of the problems that we currently have is we do the diagnostics on site. So people have multiple visits to hospital to get a treatment plan or a pathway. And having all of that together and then having me turn up means I don't have to keep getting in my car and going somewhere. And I think that at the opposite end of that, we discharge people home. We discharge people from an environment where we deliver a lot of things to them and we look after them. And then we just expect them to get on with things until their next appointment. Whereas I can contact somebody, I can contact either you, John, or one of your team, one of them clinical nurse specialists, who can help me and support me. And that type of treatment has existed for years in some specialties, like, for instance, ophthalmology, where people can be at home on their own, but they can call in and say, I've got a real problem, I've got pain, I've got redness, what do I do? With this, we can have that conversation really quickly. So I support what you're saying. This is not just about video. This is about sending somebody a text, a WhatsApp, sending somebody an email, calling them on a telephone. And we know that those things exist and have existed for years. We can also use them as triage. So most good MSK services around the country have a single point of contact for triage, where a referrer or a patient can contact an organisation, they talk to an expert, and they start planning their care. So I think there are a load of things that make this sustainable. There are a load of things that help improve patient care with them. And it is significantly more convenient. From a whole change management perspective and redesign perspective, the less people who turn up in hospital, the less we need the outpatient space, the more we can use that space for other things, inpatient space, education, whatever we choose to use it for.
Yeah, so very much touching on the transforming real estate.
Yeah.
In your last point there, and I was interested in what you're saying around the, I guess, the whole subject of patient choice. So really providing an array of different options, different ways of connecting, whether that's text, whether it's phone, whether it's in person, whether it's video, but giving the patient choice. What would you say from the other angle, the clinician's preference and the maybe what's best for that particular clinical requirement, or maybe the personal preference or method or work practice that particular clinician may have?
I mean, we've got some interesting data on this actually, Alex. When we look at our patient feedback, we're sort of seeing positive feedback in most parameters in the 80 to 90% percentile or above. Whereas when we talk to our clinicians and we ask them about have they been able to get enough information in a remote consultation, was it an appropriate tool or contact method for a given consultation, we're getting less positive feedback than we're seeing from our patients. And we think that that's because of the way we were using remote consultation in the context of responding to the pandemic. We weren't really providing much choice. And so consultations that would have actually been better delivered face to face were being done remotely. And so we were getting less positive feedback from our clinicians, and we're hoping to see that shift as we're using it in a more appropriate way and actually a more targeted way for more and using it for more appropriate encounters. So clinicians, in my experience, although they have been supportive, have not found it as positive as our patients have.
And I think actually it's incredibly valuable with the experience and the data that you've been able to gather at Birmingham Community Healthcare. Maybe it'd be worth just giving a second or two around the different data points you've been looking at, because you've got a huge amount, haven't you, over the last 20 months?
The advantage of the video consultation platform we use, Attend Anywhere, is that you can have a pop-up window with a questionnaire that can be filled out by the patient or the staff member immediately after the consultation. So we have managed to collect a huge amount of data, primarily around experience, although we have quite a lot of demographic data that associates with that experience data for our patients. We've also got quite a lot of free text data that we're looking at doing a sort of thematic analysis on. But yeah, probably into any more detail than that, but it has been useful in informing our rollout and how we use remote consultation going forwards.
Yeah, very good. And I'd be interested in both of yous. You kind of touched on it there, John, around how that change is actually evolving. Is this being driven by individual clinicians and their initiative? Who are the champions for change that you see really making this big shift?
So in our organisation, it's been very much about clinical leadership, and there's a number of super users out there who are really pushing this forward. And it's been interesting to see that it's been in particular specialties where things have really moved forward very quickly. So Steve mentioned earlier MSK. MSK have been huge users of remote consultation. Other therapy services, so speech and language therapy, have been using a lot of remote consultation, and they've been really willing to talk about their experiences, and they've taken other staff members with them. That being said, there is still a huge opportunity to do more, and so we do have the specialties who have really gone with remote consultation, but we still have a number of specialties where they're just dipped a toe in, and so I think that's where we're focusing next, and that's where the next part of the change will be. And one of the things that we're looking at is developing an optimization tool that's going to allow us to say, what are you doing now? What's your potential future state? What have other people done in a similar clinical situation? And using use cases to help services to develop in that way.
That's great. Any thoughts around that, Steve, around the kind of champions for change and what John just touched on around sharing best practice and use cases with and bringing others on that journey?
Yeah, I think there are two key areas for champions of change, and I think they start with clinicians. So as you said, John, those clinicians that are excited and interested by technology tend to embrace this more quickly. But the other huge champions for change are the patients. And we have to remember that lots of the people we're now interacting with grew up with a smartphone in their hand, and they don't want to go back to a style of exchange that is purely face-to-face. I've got a friend who's a clinician in Luton. He's an orthopedic clinician. And one of the things that he constantly says is that he has patients come to see him in hospital, and they'll be coming to see him and then going on holiday. And they can look on their phone in the outpatient waiting area and see what time their plane takes off, whether it's on time, what the queue is like at the airport, what the journey from the airport to the hospital to the airport is like. Are there any delays in public transport or driving? But they don't know what time the doctor is going to see them because there's no information available to them in the hospital. And they would much rather do that on their phone, in their hand, as they're either going to the airport, sat in their own house, or actually being somewhere else. And I think they will drive this change. And Alex, so one other thing, I'm really passionate about what we do with children with long-term conditions. And I think there are different groups of children with long-term conditions, but every one of them, we require them to come out of school, to come and see us in a hospital, and to take half a day out of their life, 2, 3, 4, 5, even 6 times a year. If their parents are paid on a contract which doesn't just allow them to take time off whenever they want to go and support their family, then not only does the child lose education, but the family loses income. And digital poverty is a really, really important thing. So I think we should be looking to use this product within school nursing. So in my world, every school in the country would have one of these in, so that kids could go, could sit, could talk to John as a consultant for 10 minutes, and then could go back to their classroom. The challenge around that is around safeguarding and around governance, but we understand how to deal with safeguarding and governance, and we deal with it in hospitals and in schools all the time. So I don't see that as a barrier. I don't know how to achieve that, and it's one of my passions, but I genuinely think that's what we should be doing.
And it kind of comes back to that whole patient choice piece, doesn't it? Whether the preference for that particular patient is, using their smartphone to dial in remotely, or whether actually their preference or maybe their need is to be physically, face to face within the hospital environment somewhere. And I think one complements the other. There is no conflict here. By creating choice, we actually create the space for both of those conversations to be able to be carried out effectively.
Agreed. One of the things I think it's worth saying is we're not looking for these pods to replace people's offices. So we're not suggesting that we put somebody in a pod all day, every day, and that they work in that very small room. We're looking for these to be used for specific things. And as you say, we want a mix and match.
Yeah. And you touched earlier on the whole subject of children with longer term conditions. Would you see that extending to other longer term conditions? Be interested in your viewpoint around that, Steve.
I think that there are a lot of long-term conditions that we've tried really hard to give back to GPs, to give back to primary care rather, sorry, not GPs. And primary care wants in the main to be the guardians of that care. But there are some things they just don't feel that they have the knowledge and skill and up-to-date information to be able to do. One that I think is an example, certainly where I live, clinicians aren't keen on being the sole deliverers of care for people with diabetes. I think we could have one of the real advantages of having a virtual world is that multiple clinicians can log in and be responsible for care at any one time. So a GP could say, I have a person with a long-term condition. He's been under your care. He's coming to see me. Can we spend 5 minutes together with him and then you log off and I'll finish it? So I think most long-term conditions would benefit from having this. Can I make a small observation? Mayor Khan of London, Sadiq Khan, he's got some very, very firm ideas about some things. I don't agree with all of his politics, but one of his things that he says is that 20% of all journeys in London are people going to and coming from hospital. And the biggest proportion of those are outpatients. And he is absolutely adamant that we should reduce that number and reduce that burden on the transport system, on the environment, the ultra-low emission zone. And if for nothing else, keeping people away from hospital helps with our management of pollution.
Yeah, very true. I know I was looking at some data the other day where I think there were less than 5,000 virtual or remote consultations per month happening prior to COVID. This is nationally. By the end of March 2021, we were running at 340,000 virtual consultations a month. And the estimation was that had saved 530 years of travel and waiting time, saved 78 million patient travel miles, helped avoid 3 million hours of adult patient time off work, costing the economy of £108 million. And a really interesting one is they also reckon that had saved 11 million PPE items. So all of the PPE items that would have been required should that patient have been physically in the hospital. And that's the equivalent of 11 million shopping bags or 110 million plastic straws. So some very interesting data out there. How you calculate that, I have no idea, but it kind of makes sense. Be interested, John, in your viewpoint now as well on what Steve was saying.
Just before you answer, John, how many plastic straws does it take to replace a mask? Sorry.
We'll come back to you on that, Steve.
Not a question I can answer, I think. But yeah, I mean, thinking about what you were talking about, Steve, I think there is an opportunity here because STPs are moving towards becoming ICSs. And actually, there is an expectation there's going to be more integrated work across systems. And if we actually think about estates rationalisation and outpatient transformation in that context, then you can target some of these benefits. And there's actually a reason for people to work together to achieve it. I think now we're at the stage where we're moving towards what is business as usual going to look like with remote consultation and how we're going to use it in the future. But I think we have to do that by looking at our our outpatient journey, and not saying, oh, this is just a tool in isolation. I think it's fundamental about how we look at that, and how we look at that in the context of how we use our estates, and how people within our regions are moving between areas within our estates as within the system, not just as individual healthcare providers.
Yeah.
And that comes back to the school piece. Can we be utilising? We can also be utilising things like public libraries, other council home properties, and that can work into digital poverty. One thing that we've been looking at with Spacester, looking at the pods, is how can we potentially use those to provide access to internet-enabled devices for people who don't have access in their own homes, so that they can access remote consultations. And so if we have this as part of the way we're looking at moving into a more system-wide approach to working, then I think this is a real opportunity, and it should all be part and parcel. But I wouldn't divorce out like the remote consultation element and sort of look at that on its own. It's part of the overall outpatient transformation, and I think there's huge potential opportunities if we think of it in those terms. And then we can sort of think about, well, what is our health estate, and what is it there to do, and what is a hospital of the future going to look like? And then you get into things like, well, virtual wards, remote monitoring, PIFU, and all of these things can be brought together, and actually you potentially in the future could have a much leaner estate. And that's something that we've been thinking about long term. We're not there yet because we haven't fully made the transformation. We're doing quite well with remote consultation, but we don't know what our stable long-term footing is going to be. But once we've got to that place, then we can start looking at estate rationalisation around that. But it would be helpful to do that in partnership across our ICS, so we can look at how the system would work.
Sorry, go on, Steve.
There are other things as well that we're not yet talking about here, that in parts of the country where we have great transport links, good connections, then having an outpatient appointment to go to a hospital is one thing to consider. If one lives in Cornwall or Devon or Norfolk, for instance, I think is one of our larger counties, and there are 4 hospitals in Norfolk. There's one in Bury St Edmunds, one in Kings Lynn, one in Norwich, and one in Great Yarmouth. And if you live anywhere else other than that, you have to get to that hospital, which then has lots of stuff around it. Now, we've talked about digital poverty, but if you don't have a car, and there are a lot of people who don't have a car for personal choice or for affordability, your journey then becomes more than just an hour's journey. It becomes a huge effort. And using this as a technology opens up and enables those people to get better access. There's something else. We have lots of services now that we run. Back to my long-term conditions thing, Alex. Other countries do this much better than we do. Canada has such vast areas to cover that they monitor their people with sleep apnea remotely. So people will put themselves on a machine overnight. The machine will monitor what's happening. They'll have a monitor that measures their oxygen, that measures their breathing rate, and that will feed stuff back to a central point where somebody will then talk to that patient the following morning, either on video link up or just on a telephone call, to say, these things occurred last night, so I'm going to change your regime, and I'm going to do this to your oxygen, this to your respiration rate, and this to whatever else. That truly is virtual care in a perfect world. And we could use this again to make sure that we do that sort of care and we improve services for patients.
Yeah, and it very much feels like we're kind of approaching a bit of a fork in the road where there's great opportunities. And as you say, if we fast forwarded 5 or 10 years, the whole shape of hospital real estate particularly, but the real estate footprint generally could be very, very different, given all of these opportunities for altering how the patient would interact with the clinician. Just slightly segueing off that point, we've got a question from Emma Sunzu in the chat. asking whether there would be any payment or funding related barriers that could affect the efficient delivery of virtual/remote consultations. So thanks for putting the question in, Emma. Would be very glad to have any other questions as well. Feel free to pop those in the chat. But any comments on that, Steve?
Every organisation works to a budget, and every organisation has to make that money stretch, and it's tough. At the moment, we're not doing a great deal in the NHS about running our budgets tight. So there's money at the moment, and I think there's lots of money that we should be accessing. But NHSX and digital are looking to spend money on initiatives and programs like this. Is there specific money identified? No. Should we be chasing it? Should we be driving this through our line managers and our divisional finance teams? Absolutely. Our estates directors, back to the one point John made earlier in estate rationalisation, if we could free up space within an estate so we didn't have a building that we were paying capital charges and rates on, we would have more money to spend on digital infrastructure instead of physical infrastructure. So yes, there is money, but it's not specifically badged and specifically identified.
Any thoughts on that from your own experience, John? I know you've been working with your estates team.
Yeah, so I mean, I think there are potential cash releasing opportunities using remote consultation. The first that comes to mind is the fact that not in every situation, but in an awful lot of contacts, remote consultation is much more transactional and it's often quicker. And so potentially you can increase capacity. And at the moment, the tariff is remaining the same. That probably won't be the case forever. But it is remaining the same to allow this transformation. What we said in our organisation is that we would want to be equitable in the way that benefit is that benefit is used. So we don't want to just say, oh well, it's half the time in the consultation, so you'll see an extra 50% more patient to our clinical staff. We're saying, well, maybe you'll see an extra 20 to 25% contacts, and then the rest of the time you can use to do some of the other stuff that actually is part of your job role. So that's one thing, and then another thing that we've been looking at, particularly in the Midlands region, is that provider organisations, we're all doing this together. We're all having to do this. And so we've actually done a regional procurement for remote consultation, and that's actually had significant financial benefits by us working together and procuring at significant scale. And so I'd suggest that there are opportunities there as well. So yeah, money's always going to be a barrier, but I think this can be, there are things that you can do to smooth the way with this one in particular.
Yeah, and interested in your point around the way the whole funding model and tariffs may work in the future. So watch this space. Good. And what would you say from your own experience, John, around the experiments and trials that you've been doing in the different types of environments? I know we've been working together, haven't we, using some of the Space Store products to facilitate and to provide an environment for those video type consultations, but kind of bigger picture, that's part of a lot more or a lot wider approach that you guys are taking, isn't it?
Yeah, so we've been thinking about how we use our estate, and particularly office estate, because we don't want to be using valuable clinical estate to be providing remote consultations. I mean, there is an argument that you can run hybrid clinics, but if you have a clinic room that's optimised for seeing someone face to face, then why would you be using that expensive clinical estate to deliver remote consultations when you could be doing that for an office? But in common with many other organisations, the bulk of our office space is open plan. And is that necessarily an ideal environment to be providing patient care? And so one of the things that we're looking at with the consultation pods is that something that we can use to make our open plan office space more flexible. And so we trialled it with some of our clinicians, MSK service physiotherapists, and they did actually get on with it very well. And so that's a potential use case that we're looking at. But then the other use case that we were talking about is the sort of digital poverty use case, and getting some digital locks on these and potentially some remote monitoring devices in them. and putting them into public spaces within our ICS. So things like public libraries, etc. So they're the two main use cases that we're looking at the moment, and hopefully we're going to be progressing that internally, but also in partnership with other members of our ICS, because actually I think something like this, it needs to be joined up, particularly the digital poverty piece. That isn't something that individual provider organisations can address on their own, I think.
Yeah, it's a big topic, and as you say, it needs a joined up approach, because there's so many different stakeholders who've got an impact on that, and the ability to receive the benefit of getting it right.
Can I add one other thing to what you've just said, John? Imaging departments, we built our departments 20, 30, 40 years ago, and we called them X-ray departments because we only had one modality of machine. And we've changed the way we do imaging out of all recognition. So plain film X-ray is still the largest modality in terms of numbers of procedures or number of tests that we do, but it's not where we get most of our information from anymore, and it's not where we spend most of our money. And an X-ray department in an average place now has 5 times as many consultants as they did when we built these organizations, and we haven't built 5 times as many rooms. And following what you were saying, John, about it's not a perfect place for doing patient consultation, it's also not a perfect place for doing reporting. And some places have built multi-person desks in darkened rooms where they go to, but there's also an opportunity to use the larger pods that we've got here for diagnostics, for both imaging and for pathology. And we just have to be realistic and accept we don't have enough offices. We're not going to build more offices. If somebody were to say that a priority in a hospital is to build a new office block, the Daily Mail would beat us to death. So we may as well be looking at an alternative to this.
Yeah, and certainly from a sustainability and future flexibility standpoint, that's what many of the Spacestore clients have really appreciated, is the ability to not just rapidly deploy. You could have a new room installed this evening and it could be ready for use tomorrow morning, but also you have that flexibility of, in 6 months' time, things may change. We can actually dismantle, reconfigure, reuse, repurpose that room in some other way without having to tear down drywall, without having to send a load of waste to landfill. So there's a whole load of aspects to that, which would definitely play into the bigger benefit that this would bring to any trust. We talked a little bit around, just conscious we're coming to our last few minutes, and thanks again for all the audience who've joined us. Thanks again to our panelists for their thoughts and sharing their insights. We talked a little bit about some of the specific specialisms. We talked about speech and language therapy. MSK was another one that you mentioned, John. Mental health is one which has come up in conversation a number of times with a number of trusts. Be interested in any kind of either insights for your own personal experience or viewpoints you could share around that or other specialisms that this may be applicable to.
So in our trust, our learning disability service is actually doing the most remote consultations of all of our separate divisions. They're probably doing about 50% of their overall activity remotely. The bulk of that is actually by telephone, but we have had some feedback by some members of staff who've said that video really does bring something else to that encounter, because it allows you to have sight of the individual, and you can make that global assessment on do they look well, and pick up on non-verbal cues. I think that there have been some issues with remote consultation in our learning disability services, and that's down to accessing technology, and so that there is an element around digital inclusion and what we can do to foster that, to make it simpler for people to access technology. But there's been some very nice innovative work that's been done by speech and language therapists within that division, developing easy read documents to help people through the process. So there are things that can be done, but yeah, mental health is a definite area where remote consultation appears to have some advantages, not necessarily over face-to-face, but has some advantages in the appropriate situation. I think what Steve mentioned earlier about long-term conditions in children, I would say long-term conditions in all patients, adults included, that there is an advantage in remote consultation, particularly if you're doing check-ins. Rather than bringing a patient all the way in to sit there and have a quick chat to make sure that they're okay, well, can't you look at redesigning that outpatient pathway to A, include a patient-initiated follow-up, and B, if that's not appropriate or deemed safe, do you have to bring someone in for a physical contact when actually you're contacting them to see how they are? And so I think that's something that you can really look at with remote consultation.
Yeah, very good. Any thoughts on that, Steve? Any other additional comments to add on that point?
Yeah, a couple of things. One that you would expect me to say, which is within mental health, I think CAMS, so children and adolescents, again, we shouldn't be bringing people, if we don't need to, into a central place. We should be keeping them where they've got their normal lives and their normal education, etc. But the thing about PIFU I really like is that I think that a significant percentage of all patient-initiated follow-up we could do remotely. The fact that the patient has initiated, in the main, would indicate that they have signs rather than symptoms, and therefore that we could use this as a really good way of keeping those people away from hospital. And it's interesting, we talked about the pandemic earlier, and we've talked about the fact that the pandemic is going. But for years and years and years, we've known the most dangerous place to be if you're not very well is in a hospital, because there's lots of infections in there. And so, again, this is just about good practice that we've been espousing for decades.
Very good. And I think kind of plays into to me anyway, one of the big points that we've discussed, which is around that the ability to offer choice, but also to offer a blended approach that works for everybody, so that people can get the clinical interaction that they need, but also to fit that with their own preferred methodology or modality of connecting with people, whether that's physically, face-to-face, virtually or remotely using phone, video or some other virtual method. Very good. And I guess just maybe just to wrap up, there's another question which was just kind of in the back of my mind as to how can we optimize remotes, and how can we kind of where do we go from here, I guess, is really the question in my mind. How can we optimize all these different initiatives we've spoken about? And I know, John, you've been doing a lot of work across multiple areas. Be interested in kind of your viewpoint on that and how you're moving forward at this stage.
So at the moment, we're actually trying to get some funding to do a sort of regional piece of work that will hopefully have national implications when it's completed. And we're actually trying to develop an optimization tool. And the idea behind the optimizational tool is really about what does this 25% of remote consultations mean, and is that actually a meaningful figure, and is that realistic? And so what we're trying to find out is what are services doing now, what can they potentially do in the future, and how can they do that? And to do that, it's really about informing them through use cases. So we're trying to create a library of use cases for relevant specialties, and a metric that allows services to sort of have a data-driven structured conversation to work out where they are now and where they can be in the future. That's very operational, and it's about getting services to do more with remote consultation. But then there's lots of enablers around that, and I think that then feeds into how do you transform the whole outpatient pathway, how can you use technology to enable that, and then what impact is that going to have on the way we use our estates, and do we have a joined up approach across systems to make that happen?
Good. Well, there's some great closing thoughts there. Anything you'd like to add, Steve? I think we're right at the end of our time now. So again, thanks for joining, both of you, but glad your final thoughts, Steve.
Nothing really on top of that, other than I think patients will determine whether or not this is successful. And I think in the main, as a society, we have moved more towards virtual communication. So I think we need to engage with people who use the service to ask them what they want and then mold this to be what they want. And there are great examples around the country of people who've done that within particular specialties.
Very good. Well, again, thank you so much for both of you for joining and sharing your thoughts, and thank you too to the audience. Thanks for the questions we've had in. Hope you found this has been an insightful and you've learned something. I certainly have. We'd love to invite you to continue this conversation. So if you wanted to reach out to myself or one of the team here, we've just popped in some links into the chat box, so you could choose to come and visit one of Space Store's working design centre locations to look at the products and see how they may work either physically or virtually, or you could join us in one of our showroom open days. And we're also going to be continuing this conversation in a webinar in around 2 months' time in March, so this is going to be a continuously evolving discussion. We'd love to invite you to register and join us, but I think that brings us to the close. Again, many thanks to everyone, and thanks especially to our panelists for sharing their thoughts. Thanks, and have a fantastic rest of your day.
Cheers.
Thank you.
Thanks, John. Thanks, Steve.
Cheers. Bye.